Right, it is at the top of the hour. Good morning, good afternoon, and good evening, depending on wherever you are. Thank you once again for joining our session today. Thank you. I was just going to mention that. Yeah, so thank you for noting that, Ellie. Maybe I should start with that. We have French language interpretation here in this session. So kindly choose the language of your choice. It is important that you choose either French and stay on that channel, or you choose English. We discourage you to stay on the off channel. So choose any one of those two. This will be a 1 hour long session, which will start with some presentations followed by a Q&A. And today we have our guest moderators from the GLI who moderate this session. And we have an interesting topic that is going to talk about diagnostics in TB, particularly the TB Lateral-Flow LAM Assay. Without taking much time, let me hand over to Kathleen England to take us through the presentation today. Kathleen,
hello. Welcome, everyone. Welcome to the first webinar series from the Stop TB Partnerships Global Laboratory Initiatives Working Group. I'm going to shut off my video, and then I just wanted to say hello so you can see who I was. I'm Kathleen England, and I am a laboratory and diagnostics specialist for TB and HIV. Been working for several years in the field, about 12, 15 years in research and implementation and development. And so I want to start this webinar with an explanation, a little bit of an explanation about the GLI. So the GLI mission, the mission of the GLI and its partners is to serve as a collaborative platform for the development and uptake of practical guidance and tools for building and sustaining high quality TB diagnostic networks. So today we want to talk about the use and the implementation of TB-LAM assays. Lipoarabinomannan, or LAM, as we know, is a unique molecule found in the mycobacterial cell wall. It's a detection, the detection of this biomarker is a surrogate for Mycobacterium tuberculosis, or TB infection, in high TB burden settings. The current technology for detecting LAM in urine has demonstrated success primarily in patients that are immunocompromised, particularly people living with HIV that have low CD4 counts. Many of these patients are severely ill, and thus they have a high level of LAM that's excreted in their urine. These patients typically are not able to produce a sputum sample, which is normally required for TB diagnosis, and therefore the ability to diagnose them using urine as a sample becomes extremely important. The ability to detect LAM in urine using standard antigen antibody lateral flow technology has improved the diagnostic yield and demonstrated decreased mortality rates within this specific patient group. However, the accuracy of the current test remains suboptimal. Thus, the uptake of this test has been limited. Currently, a significant amount of research and development is underway to design a better LAM assay with improved detection to expand the utility for diagnosis for any or all symptomatic individuals. So today, the GLI has partnered with the ASLM to share information on, one, the application and use of the new GLI practical guide for implementing TB-LAM assays to detect TB in people living with HIV. Two, to provide updates on the progress of the advanced HIV disease package of care within HIV programs, which includes the currently WHO recommended LAM assay for screening. And three, to share updates on the landscape and the development of next generation TB-LAM assays. So again, there's 3 presentations. There'll be a Q&A after the final presentation, and we would like you to put your questions in the chat as normal as we go through the presentations, and we'll have the Q&A afterwards. Prior to the Q&A session or in the Q&A session, there will be one survey question that we would like participants to answer. So we hope that the information today will provide guidance and advocate for TB and HIV programs to uptake the current and future LAM assays. I will hand it over to Elisa Tagliani, our chair of the GLI, to introduce herself and the speakers.
Good morning, everyone. Thank you, Kathleen. So my name is Elisa Tagliani, and I'm a research scientist at the San Raffaele Scientific Institute, Milan, which is a supranational reference laboratory. And now, without any further ado, I'm very pleased to introduce the first speaker of today, Dr. Martina Casenghi. She's a friend. And so she's a technical director of the CAP-TB project of the Elizabeth Gleiser Pediatric AIDS Foundation, ECPAF, since 2016. She's a former member of the GLI working group and co-led the development of the GLI guide on the use of LF-LAM. So please, Martina, the floor is yours. Thank you.
Thank you very much, Elisa. And thanks a lot for the opportunity to present the GLI guide to this wide and important audience. I'm going to deactivate my video just to ensure that the presentation goes smoothly. So before jumping into the content of the GLI guide, let me give you a quick introduction to the LAM as a biomarker for TB diagnosis. I will repeat some of the concepts that Kathleen just mentioned. So LAM is a component of the microbacterial cell wall. The evidence show that can be found in different sample types, such as sputum, urine, and blood, but the concentration of this biomarker varies in these different sample types, being higher in sputum, and then a little bit lower in urine, and then the lowest concentration can be found in blood. So urine is, of course, a very interesting sample because it's easy to collect and has less biosafety requirements compared to sputum. The other important things to highlight here, as Kathleen already mentioned, is that the concentration, the evidence again show that the concentration of LAM in urine is higher in patients who are TB and HIV co-infected. The biological reasons for this are not fully understood. An hypothesis is that this is due to the fact that due to immunosuppression in TB, HIV co-infected patients, there is a higher bacterial load, and as a consequence, a higher concentration of LAM in the urine. The other hypothesis is that in TB HIV co-infected patients, more frequently, there is an infection of the kidneys, and therefore LAM gets secreted in the urine more efficiently, let's say. So in a way, it's also a marker of disseminated TB. Now, for the time being, the only commercially available rapid test that is based on the detection of LAM for TB diagnosis is the ALERE determined TB LAM antigen test. As I mentioned, is a lateral-flow assay. And as a matter of fact, until now, is the only truly point-of-care test that is available for TB diagnosis. It's based on urine, which is, as I mentioned, a sample easy to collect. And it is a rapid test, so the turnaround time to results is 25 minutes, and therefore can really support same-day diagnosis. When it comes to the sensitivity, we will discuss this in greater details in the next slide, but I wanted to highlight here that, as Kathleen mentioned, the sensitivity is higher in the population living with HIV. So here you can see the sensitivity in symptomatic people living with HIV, all settings. The reported pooled sensitivity is 42% versus 18% in the HIV negative population. Of course, when compared to expert, the sensitivity is lower, but compared to expert, lateral flow LAM has some key advantages. First is instrument free, therefore is much more suitable for decentralization. It's cheaper compared to an expert test. It really supports, it has been shown to really support same-day diagnosis. And then last but not least, it has also been shown to have an impact on mortality. So the study by Peters and al. Published in 2016 showed that the use of lateral flow LAM for TB diagnosis in people, in symptomatic people living with HIV in inpatient settings led to a decrease on 8 weeks mortality. So why is lateral flow LAM a useful addition to the TB diagnostic algorithm? So in the last few years, there has been compelling evidence showing that the addition of urine lateral flow LAM to the diagnostic algorithm for management of either hospitalized or ambulatory HIV people living with HIV can significantly increase the diagnostic yield. Although less significant, an increase in diagnostic yield can also be observed when lateral flow LAM is added to the diagnostic algorithm that includes expert MTB-RIF. And in particular, LAM is really useful for patients who cannot produce sputum, as you can imagine, and when expert is not available on site. Lastly, it's also really important, the fact that lateral flow LAM can support same-day diagnosis or rapid diagnosis, and this is really valuable for the people living with HIV who are at higher risk of mortality, where the rapidity of coming up with a diagnosis and starting patients on treatment, it's really critical. In these two tables here, I have summarized the pooled sensitivity and pooled specificity as reported by the latest Cochrane review that assessed the accuracy of lateral flow LAM, of the LAM. I will not go into all the details, but what I wanted to highlight here is that the performance of lateral flow LAM varies depending on the target population. So for instance, whether the people living with HIV are positive to TB symptom-based screening, so they are symptomatic, or whether this is used in people living with HIV irrespective of signs and symptoms of TB. It also depends on the settings. As you can see, there is variability whether the test is used in populations that are presenting at the inpatient settings versus outpatients, with the sensitivity being higher in the inpatient settings. And last but not least, also the evidence show that the performance of lateral flow LAM varies depending on CD4 count, with the pool sensitivity increasing and the specificity decreasing with a decreasing CD4 count. So based on this evidence and the increasing body of evidence generated during the last few years, the WHO decided to update the policy guidance regarding the use of lateral flow LAM in 2019. So compared to the initial guidance issued in 2015, the 2019 guidance is characterized by the increased strength of recommendation, improved quality of evidence, and also a revision of the target population, an expansion of the target population eligible for lateral flow LAM. And also in 2020, WHO released the updated templates for lateral flow LAM algorithm in the WHO Operational Handbook on TB Module 3 Diagnosis. This is where these updated algorithms can be found. And then last but not least, the GLI decided to develop this practical guidance to help implementers, national programs really introducing and rolling out lateral flow LAM under routine conditions in countries. And this guidance is, of course, fully aligned with the latest WHO guidance released in 2019 and 2020. So the GLI practical guide, let me now go into the content of the guide. It is focused on the commercially available test, which is, as I mentioned, for the time being, we are talking only about the LR-determined TB LAM antigen test. The target audience is national TB and HIV programs, frontline healthcare workers, both working on the laboratory side, but as well as clinicians and implementers. In terms of the context, it includes some basics about lateral flow LAM and the assay principles. And then it reviews the role of lateral flow LAM in the TB diagnostic algorithm. in line with what was published in the operational handbook. It also includes practical considerations for country introduction and rollout, considerations about quality assurance, procurement, and then finally also a detailed laboratory SOP. I will not go through all of them. I just picked some of what we thought were the more important aspects to highlight. So when it comes to the diagnostic algorithm, this is, as I mentioned, aligned with the latest WHO guidance released in 2019. And WHO has recommended the use of lateral-flow LAM for inpatient settings and outpatient settings. And there is some little variation depending on these two populations. So in inpatient settings, WHO strongly recommends the use of lateral-flow LAM to assist in TB diagnosis. People living with HIV, all ages, with signs and symptoms of TB, irrespective of CD4 count. And then if the patients present without signs and symptoms or irrespective of signs and symptoms of TB, the lateral-flow LAM is recommended for use if the patients present with advanced HIV disease or are seriously ill, or with a CD4 count below 200. When it comes to the outpatient settings, WHO recommends the use of lateral-flow LAM for assisting in the diagnosis of active TB disease in patients that present with signs and symptoms of TB and are seriously ill, irrespective of CD4 count, or irrespective of signs and symptoms if the patients have a CD4 count of less than 100. So I will not go into the details of the algorithm. These are the template algorithms, the model algorithm that WHO has developed, and that they are included in the WHO operational handbook. And we thought to highlight this to all of you because they can be, a useful starting point for adaptation when it comes to national algorithm and guidelines. This is the algorithm for the inpatient settings. The most important things to highlight here is that the lateral-flow LAM test and WHO recommended a rapid diagnostic test, molecular-based tests, such as, for instance, expert, should be done in parallel whenever possible. That TB treatment can be started based on a positive lateral-flow LAM result. A negative lateral-flow test result cannot rule out active TB. So in the presence of a supportive clinical judgment, still TB treatment should be considered. And then children below 5 years are considered as having advanced HIV disease unless they have been receiving ARVs for more than 12 months and are clinically stable. So also children are eligible based on this definition to be tested with lateral-flow LAM. And this is the template model algorithm for the outpatient settings, and yeah, the main considerations are basically the same. The main things to highlight here is that for the patients presenting in outpatient settings without TB signs and symptoms and not seriously ill, actually the CD4 threshold is below 100 rather than below 200, which is what has been chosen as a threshold for the patients presenting to inpatient settings. So the guide also includes practical considerations for introduction and rollout in countries. Many of those considerations are common to the different, all the different diagnostic tests that are introduced in countries. What I would like to highlight here are the ones that are a bit more specific to lateral-flow LAM, and in particular the importance of establishing a working group or platform that are gathering both HIV and TB technical experts in order to really develop a cohesive and coordinated plan for introduction of lateral-flow LAM, and also develop in a coordinated fashion the national policies as well as the diagnostic algorithm. it's really important to define and agree on the target population and the placement of lateral flow LAM in healthcare settings, to define the placement in the diagnostic algorithm. So as we said, we have templates, but they need to be adapted to the local context. And then, very importantly, WHO has decided that the recording and reporting of lateral flow LAM positive results needs to be basically reported as a bacteriologically confirmed. So even if it is a biomarker-based test, still the results of this test needs to be recorded and reported as bacteriologically confirmed. Also, the guides kind of reviews, the results of the experience of early implementation by some key implementers in terms of training needs, location for test performance, availability of practical considerations such as availability of sanitary services, and also patient flow in case also CD4 testing is required. So in terms of training needs, it's really important to involve both lab as well as clinical personnel. It's really important to be very clear on the eligibility for lateral flow LAM testing, the adherence to the diagnostic algorithm, especially for negative results and for testing for drug resistance. And then, importantly, the early experience have showed that it's feasible to perform this test in consultation rooms. So really, it's a bedside test. And then, it's important when it comes to the facility level implementation also to ensure privacy for sample collection and availability of places to safely dispose the urine samples. The test also includes guidance on test performance. I want to highlight again that there is a detailed SOP included as an annex, and the GLI guide provides information on the supply needed for performance of the test, including also items that are not included in the kits provided by Alere. That the sample collection and sample storage conditions and timelines are also described. And then, as I mentioned, there is the SOP that really details the procedures. We also discuss in the guide the results readout and interpretation with the importance of using the reference card to really support the correct interpretation of the results, as well as the biosafety and waste disposal. Last but not least, there is also guidance or information regarding the procurement. So there is the guides include a detailed list of items that are needed for the performance of the test, and that they are currently available through the Global Drug Facility, GDF. Also, the guide includes a methodology for initial quantification of the test, of the lateral flow LAM assays. I want to highlight also that GDF has developed their own, dedicated and detailed guidance on how to procure lateral flow LAM, and you can see it here. And so it's another useful resource that is available. And with this, I come to an end, and I would like really to thank the GLI core group, the two chairs, Elisa Tagliani and Patricia Hall, the group, the task force that has led the development of this guide, composed by Kathleen England, Lise Gonzalez Angulo, Wayne Van Giemert, Petra Diaz, and Eder Alexander. And then, of course, Marcila de Melo Freitas was working with us as a consultant to help us developing the guide. And then key partners such as FIND and MSF for their key input in this document. Thank you very much.
Thank you, Martina. Thanks.
Elisa, can you introduce the next speaker?
Sure. So we will take the questions at the end of the three presentations. So our next speaker is Dr. Nathan Ford. Nathan is a scientific officer working in treatment, care, and service delivery within the Global HIV, Hepatitis, and STI Department of the WHO in Geneva, and is the chairperson of the WHO Guidelines Review Committee. He also contributed to the coordination and development of the guidelines for managing advanced HIV disease and rapid initiation of antiretroviral therapy. So Nathan, the floor is yours.
Good day. Thank you very much for the introduction and the offer to be able to speak at this session. So my name is Nathan Ford. I work in the Department of HIV, Viral Hepatitis and STIs at WHO, and I'm going to give a brief summary of the WHO recommended package of care for advanced HIV disease. So the approach to responding to advanced HIV disease was initially informed by a systematic review which looked at causes of hospital admission and in-hospital mortality among people living with HIV. And this review highlighted that tuberculosis, cryptococcal meningitis, and severe bacterial infections were leading causes of hospital admission and adverse hospital outcomes. Around the same time, in mid-2015 onwards, two large randomized trials were published which informed the package of care that could be provided to people presenting with advanced HIV disease in order to reduce morbidity and mortality. These two trials, REMSTART and REALITY, REMSTART published in 2015 and REALITY published in 2017, were both conducted in sub-Saharan Africa. One used a diagnostic-driven approach, and the other used an approach to providing blanket prophylaxis to people presenting with advanced HIV disease. Both of these trials, so both of these approaches, diagnostic-driven approach or a prophylaxis-driven approach, found a significant difference in mortality reduction associated with individuals presenting with advanced disease who were given the package of care. So in 2017, in response to these trial results, WHO published a guideline for managing advanced HIV disease, drawing on the evidence from these two trials, plus associated information, to recommend a package of interventions, including screening, treatment and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensified adherence support interventions should all be offered to people presenting with advanced HIV disease. And also in this guideline, a recommendation on rapid ART initiation, including starting antiretroviral therapy on the same day that a diagnosis is made, be recommended. And both the provision of the package of care and rapid ART initiation were strong recommendations. So this table summarizes each of the components of the package of care that are laid out. It includes diagnostics for TB and cryptococcal meningitis, prophylaxis for bacterial infections through cotrimoxazole, TB and cryptococcal meningitis, and recommendations for rapid ART initiation and the associated provision of intensified adherence support. This slide shows relatively rapid uptake of the recommendations in these guidelines. It shows that as of last year, 67 countries had adopted the recommendation to provide a package of care for people with advanced HIV disease. This was up 10% from the previous year. And relatedly, this slide shows that in 2019, 74 countries had a policy that gave priority to people with advanced HIV disease, again, an increase over the previous period. And so finally, I just wanted to talk briefly about the next steps for WHO with advanced HIV disease. So advanced HIV disease is highlighted in a dedicated chapter of the new consolidated HIV guidelines that will be released at the conference of the International AIDS Society in a few weeks' time. Secondly, WHO in the course of the coming year will be reviewing the core components of the package of care, giving specific attention to potential interventions to reduce mortality associated with severe bacterial infections. And finally, WHO is looking to see whether there are any regional adaptations to the package of care that may be needed, acknowledging a differential burden of disease in different regions, such as Latin America or Southeast Asia. So that's it from me. Thank you very much. And I'm very happy to stay here and answer questions, including via the chat. Thank you very much.
Thank you very much, Nathan. So now I will introduce the first speaker of today, Dr. Morten Ruhal. He's the head of the TB program at FIND, the Global Alliance for Diagnostics. FIND is supporting the development of new LAM-based assay by making reagents, reference material, well-characterized samples, and extensive know-how available to manufacture. So please, Morten, the floor is yours.
Thank you very much, Elisa. Can you see my slides? Can you hear me?
Yes, okay. And
great.
see your screen.
Thank you. So I will take sort of an approach looking a bit into the future with the landscape of upcoming LAM assays and some of the challenges we are seeing in the in this field. So the first next LAM assay we expect to enter the commercial space is the FUJILAM test. So I have added sort of an image of the FUJILAM test here. It's a rapid diagnostic test. And over here, I have illustrated the test procedure. So just to give you a quick overview, this is a relatively complicated test because it has, it's basically a small laboratory inside a plastic chip that is needed to drive a higher analytical sensitivity. So the first step is here, you take a urine sample and you add with a pipette a small volume of urine in a little vial. Here, an antibody that is bound to a gold molecule will find the LAM that is in the sample over a 40-minute period where the sample incubates. Then you add 2 drops into the sample port here, and then you press this button that says number 2 here. That releases a reducing reagent that pushes the liquid through this lateral flow. And over here, there is then a color change once it's made its way through. And that triggers the user to press button number 3. And then there will be in this field here, there will either be a line if the test is positive or a line if the test is negative. And as you can see, you need 1 flow going there, 1 flow going the other way in order to have an amplification of the signal, which is important because there is a very, very low level of LAM in the urine. But let's look at some clinical data, how this test performs. So this was a meta-analysis of 5 different independent studies that were based on frozen samples from Sub-Saharan Africa and Vietnam. And here they're looking at people living with HIV, 1,595, FUJILAM against the LAM that we've heard about in the previous 2 presentations. And you can see the sensitivity of the FUJILAM is around 71% compared to the LAM, which is 34%. So that's a doubling in the sensitivity at a comparable specificity. It seems to be slightly lower for Fuji here, but not significantly. And when we break this down into the individual CD4 cell groups, you can see also for this test, the sensitivity is higher with a low CD4, and then it decreases with a higher CD4 cell count. But having a test that performs with almost 90% sensitivity in this really vulnerable patient population is a vast improvement over the 56% here. The challenge is how far can we go with this test? So the LAM-based assays are really good in people living with HIV, but it would be fantastic if we could have a urine-based quick test for also non-HIV infected patients. And there's a couple of studies that have looked at this, and there are many more in the pipeline. So here in this study, there was a comparison of the LAM, the FUJI-LAM, and then a very sensitive laboratory-based method called ASLM. And you can see the sensitivity in outpatients. HIV negatives was about 11% for the ALEA, but 53% for the FUJI, and all the way up to 67% for this ASLM. This study comprised two different cohorts, one from Peru and one from South Africa. And the sensitivity in Peru was 65%, whereas the sensitivity in South Africa was very low, only about 25%. And when we looked at the individual sort of patient characteristics of the people from Peru, well, it does seem that they presented to the clinics with more advanced disease. So they were more sick, they probably had a higher bacterial load, and that was driving the improved sensitivity. So it's going to be super important and interesting to see how this test performs in specific use cases. There was also an analysis of the bacterial load quantified with the expert, and sort of the semi-quantitative result that comes out as the very low, medium, or high. And you can see here the sensitivity does improve with a higher bacterial load in the sputum. We talked about children earlier for the LAM, but there's also a couple of studies that are out now for the FUJI-LAM. And of course, it's a very difficult patient population to study because the reference standard, the diagnostic tools we have for children at the moment are very bad or not good enough. So here they had about 450 urine samples from 63 confirmed TB patients. So they had a microbiological test that was positive, either PCR or culture. And then 113 were considered to have TB, but the tests were negative. So they are with a clinical reference standard. And then there were 239 that were unlikely to have TB. So they were considered negative, both reference standards. I mean, when we look at the performance here, this is just one of the analysis. You can study this Lancet ID paper for many more details. But just to give you a hint on the sensitivity, again here the FUJI-LAM came out with about twice the sensitivity of the LAM, around 65%, which was quite good. The clinical reference then was lower. The composite reference standard was lower because many of these unconfirmed TB probably did not have TB. But again, here the FUJI-LAM picked up children that were not picked up with the LAM. So there's a lot of different studies that are ongoing at the moment to look at this FUJI-LAM test compared with the LAM in many different use cases. FIND is also doing a very large prospective evaluation, and we hope to be able to unblind and look at the data early next year. And WHO is currently looking at the evidence, whether they are ready to look at this for sort of a policy on this new test or not. So I'll now move into some of the challenges that are around this test and where the third generation of tests are moving. So this is just a comparison of LAM concentrations in urines from TB negatives and TB positive people with either with HIV infection or no HIV infection. And as you can see, the HIV infected have a higher response, and the lower the CD4 cell count, the higher the response. So with the LAM, we have a sensitivity of around 500 picograms. That's the analytical sensitivity, and that gives a sensitivity in the study of about 50%. The FUJI-LAM has a sensitivity of about 50 picograms, and that drives a higher diagnostic sensitivity. But where we want to be going with the third generation test is an analytical sensitivity around 10 picograms, and you can see we capture a larger population of patients here. And we expect to be able to have tests that at least have 65% sensitivity in all patients, irrespective of their HIV status or not. So how do we get there? Well, we need to look at urine LAM as a molecule first. And we always sort of bit in as a joke, we call it the broccoli. So it looks a bit like a broccoli when you sort of slice it in half. And this is how the molecule looks when you have it in a culture, in a microbacterial culture. It's a very sort of intact molecule. It's very well characterized. But once the bacteria gets eliminated by the immune system at the site of infection, it sort of breaks down, gets transported in the blood, it binds to proteins, and then eventually it ends up in the urine. And then it's many different types of parts of this broccoli molecule, or broccoli-like substance. So it becomes difficult because you actually need to capture this to be able to measure it. And we'll go back to sort of the molecular structure here of this glycolipid. The two antibodies that are binding LAM here, one goes in this region, another goes in this region, and it binds these small glycan structures here, and they are incredibly small. So antibody is a large molecule, LAM is very small. So you can sort of compare this to two buses that have to capture a broccoli molecule inside a very large swimming pool with very few broccoli molecules floating around. So if you just stay with that image, that is the challenge that the developers are facing when they try to develop these assays. So we can do this we can capture this molecule with several different approaches. But the target here is to have something that has a sensitivity, analytical sensitivity below 10 picograms. We can get that with improved reagents, and many different groups, including FIND, PATH, Rutgers, and Mologic, are developing new antibodies that are targeting different regions here. And we hope to get antibodies that bind faster than the current antibodies we're using, because that will lead to shorter incubation time and higher analytical sensitivity. Other groups are working towards concentrating urine. So we know it's possible to take the water out of urine and have a higher concentration of LAM. You can either do that with filtration, or you can add magnetic beads and that will capture the urine, and then you put a magnet on the side and you get the beads to one side. You can pour out like the urine that doesn't have any LAM. You can then remove the magnet, and then you have a higher concentration. Or you can use, as they do with the FUJI-LAM, with an amplification step, and you can do that in many different ways. And one of them would be to have a reader that reads a fluorescent bead instead of a visual read, and that tends to drive a higher analytical sensitivity. So these are just some of the approaches that are being pursued by many different manufacturers. And with this sort of more generic view into the future, I think I'll stop with a couple of take-home messages. And I think it is very important to highlight that LAM, despite it not being very sensitive, it has a very unique role in the diagnostic landscape. It provides a rapid and accessible diagnostic to the sickest patients with the worst prognosis. It's very difficult to get a sputum sample from a very sick HIV patient. You can get that with a urine sample, and you can have a quick test, and it does save lives. The FUJI-LAM is a second-generation LAM assay. In development, it has improved performance. It's more complicated to run, but I do believe there is a lot of promise for a lot of lives saved if we can get this test to the market. And then there are multiple manufacturers who are working on third-generation LAM tests with higher analytical sensitivity, but that leads to a higher diagnostic sensitivity as well. But it requires concentration of urine or readers to really deliver this performance. But I think it is practically feasible. And with all the innovations we've seen from the COVID pandemic, I think this is where we will be moving in the next couple of years. So with this, I'd like to say thanks to the funders of FIND and the team in Geneva and all our partners across the world. Thank you.
Thank you very much, Morten, and thank you to all the presenters. I think we have time for a few questions. Anafi?
Yes, we still have about 15 minutes. Please go ahead.
So I've been trying to, this is Kathleen, and I've been trying to answer some of the questions because there are many in the chat, but I do have a few selected questions for each of the speakers that have been raised. I think to Martina, there was a question of whether the test should be focused in HIV clinics or TB clinics, or how do you recommend the use?
So I think for sure the HIV entry points are a really important entry point because it's the target population, right? It's really important to, one of the challenge we see when in the countries that have started rolling out, it's a little bit of confusion on, since it's a urine-based test and it's easy, it's rapid, there is a little bit of tendency to use it outside of the target population, but it's really, really important to emphasize that it needs to be used in the people living with HIV with, the characteristics that have been highlighted in the latest WHO guidance. So for sure, HIV clinics are an important entry point. Inpatient wards are the other one, because as you could see, the performance of LAM and also the target population is larger in inpatient settings because evidence has been supportive for this. So I would say for sure, HIV outpatient clinics and inpatient settings should be a priority.
And Nathan, I guess for clarification, this test can be used as a diagnostic. So can we start ATT? Nathan?
I'm sorry, can we start? I missed the last part of your question.
Can we start ATT?
ATT?
TB treatment.
TB treatment.
So that's a question for our TB colleagues on the call.
Hi, Kathleen, this is Lisa. Our recommendations indicate that LF-LAM is to be used just as an add-on test. And we are recommending that the test is used in combination with WHO-approved rapid diagnostics. But one of the important considerations that we make, or the remarks, is that a positive result of LF-LAM could be used to initiate treatment, TB treatment.
And can you mention something about the bacterial confirmation and the new WHO's recommendations for that?
Yes, so Wayne has kindly provided the link to the WHO framework of diagnostics, where there is a clear statement that a positive LF-LAM test could be considered as bacteriological confirmation for tuberculosis. Of course, this has to be aligned with the recommendations that were last updated in 2019, and which of course are part of the consolidated guidelines as well. But again, the important remark here is that LF-LAM is to be considered an add-on test, and that we should be thinking also of scaling up other WHO-approved rapid diagnostic tests. Over to you, Kathleen.
Yes, and there's one more important question or two questions, one for Martina and one for Morten. So Martina, they want to know a little bit more about the quality assurance that's in the guide. Can you share a little bit about the QA?
So yes, unfortunately, there is not a validated, let's say, panels like, that is available for other tests to do QA. But what the guidance says, it provides a little bit of the process and methodology to use to validate the test, and using basically samples that have been stored in a proper way and for which the results on LAM is known. So as a positive control, a sample that for which the LAM test result is known, stored in an appropriate way, and as a negative control, a saline solution based basically sample. So that there is the details on how to proceed. The guide provides the details on how to proceed with this, and is also included in the SOP. But there are no panels for the moment, and Kathleen, you can correct me if I'm wrong, but there are no kind of right standard panels for EQA purposes.
Yeah, not yet. Morten, so some people were asking questions about the two cohorts and them having different sensitivity, and I'm not really sure if they mean the inpatient, outpatient, and if you could explain that. I think that's what they meant.
For the Fuji test,
Well, it's the same. It's the same. Inpatient, outpatients vary. What is the rationale behind the variance?
Oh, well, I think it's clear that inpatients are often more sick, and they will, as a general thought, have more advanced HIV with lower CD4 cell count. So they would probably have the test works better there because of this higher signal. So we always sort of do the analysis when we look at these LAM assays by splitting on inpatient and outpatient, and we also split on CD4 cell strata.
Okay, and then there were some questions about the increased when you use LAM and expert, do you get a combo effect for sensitivity and detection? I know that Stephen Lawn did a bunch of tests with Alair and studies. Can you share kind of a summary about that?
So for sure that there are patients who have a negative LAM test and a positive molecular test and vice versa. So there is an added value of combining these tests. But as Lisa mentioned, I think the LAM-based assays, they are an important tool to make the initial diagnosis for severely sick patients, to put them on treatment. And then you always have to follow up with a confirmatory bacteriological test to also capture potential drug resistance.
Exactly. And some people are asking about that in the chat about what do we do if it's positive? Well, you still have to, you can treat for sensitive, but you still have to go find out if they're resistant. So those tests will have to be done as well. But as we know, getting a sample of sputum can be challenging. So those would possibly need an induced sputum or something to get some of the bacilli to be tested in the drug susceptibility testing. Nathan, how do you foresee new tests, or how can we improve the uptake of this test? I know that the advanced HIV package is one way, but what do you feel that how the uptake of this test could be improved in countries?
So I'm afraid to defer once again to my TB colleagues, because my focus is really on the advanced disease package altogether, rather than the specific uptake of individual tests. So I would like once again to invite colleagues from the TB department to be able to complement that question.
Oh, I basically asked you mainly because I think that that's one way of getting the test in the country and getting used is your advanced HIV package.
Oh, indeed. I completely agree with you that the focus on advanced HIV disease has been an excellent opportunity to draw attention to increasing capacity for a number of very key interventions that can help save lives. I had wondered whether the question was also looking beyond the advanced disease package, in which case I'm not well placed to respond to that aspect.
Yes,
but for sure the attention raised on advanced HIV disease has been absolutely critical, also because in recent years we have noticed that mortality from HIV-associated conditions has tended to flatline. And so there has been a need to focus attention on trying to reduce HIV-associated mortality. Advanced disease gives us that impetus. Thank you.
Thank you.
And Kathleen, maybe just to complement what Nathan said, it may be important to highlight to the audience that PEPFAR has been increasingly recognizing the importance of addressing advanced HIV disease. So in the latest COP guidance, there is really strong emphasis on the need to, and PEPFAR is fully behind supporting, the scale up of implementation of advanced HIV packages, including lateral-flow LAM. So there is a clear mention about the need to make sure lateral-flow LAM rollout is included as part of this.
Yes, thank you very much, both of you. I know that there was a recent publication about the barriers for uptake. And so I wanted to stress that one of the barriers was which program should take it up and which program should have it in the budget. And so because of this, I guess I want to say indecisiveness of who should have the test, there really hasn't been a lot of budgeting for it. And so that's been one of the biggest challenges, is who's going to implement it where, and who's going to budget it. We're getting the budget and the money to allocate for implementation was one of the major reasons for the slow uptake. Another was the low performance, and that it was particularly for a small population, or what they called a niche group of people that are in the TB, that have TB. So those were some of the things that were brought up in the article by Madhu Pai's group and some of the experts that did a survey. So I think let's see what some other questions were. One of them was if maybe Morten or anybody can answer this, is has LAM been tested in other immunocompromised individuals other than HIV?
I'm more familiar with testing of other specimen types like CSF, and here it does seem to perform quite well. Pleural fluid has also been explored, not many studies. I think the challenge is probably going to be in really the important groups like children, where it doesn't seem to be sensitive enough with the current LAM. FUJILAM seems to be doing better, but for sure we probably need something even better outside of the people living with HIV.
And I think that there were questions about that same studies being in HIV negative patients. What are the studies out there that these tests have been assessed in HIV negative? Is there evidence for the current test and the new FUJILAM test?
Yes, the current test is not going to be very good. It looks to be around 10–15% sensitivity in most studies. So clearly that's not enough. The FUJILAM study I presented had a much better sensitivity, around these 40–45%, depending on studies. Some of the few studies I've seen, some have slightly higher, but it's really small patient populations. In the big study I showed, we had a big discrepancy between two populations, Peru and South Africa, and where Peru came in with a much better sensitivity than South Africa, perhaps suggesting that, or it's perhaps related to the fact that in South Africa, the patients are picked up earlier, where in Peru, many are seeking care later, so they have more advanced disease, they have more bacteria in the body, they therefore have a high LAM content. But I think we need basically more data to have confirmed, stronger conclusions on this.
Okay, Anafi, I think we have to close, right?
Yes, it's right at the top of the hour. Great. You want to
Okay.
make any closing
Thank you,
remarks?
everyone. Everyone wants to know if the PowerPoints will be shared. Yes, they will. And as on the ASLM website, they will share the PowerPoints and the video recording. Correct, Anafi?
Yes, that's correct.
So
All
thank
right.
you once again to everyone and to the presenters, and have a nice evening and afternoon.
Everybody.
Thank you. Bye-bye, everyone.
Thank you. And on your screen, we have shown the certificate code for those that want to go and download this at the ASLM Academy. Till we meet again next week. Thank you and bye-bye.